Hello. Thank you very much for inviting me to come and talk to you today about the issues of brief interventions and early intervention and treatment for young people in my case. And hopefully my presentation, there we go. So I'm the Director of Policy for Drug Scope, which is this isn't working. Oh, there we go. Drug Scope, which is the national membership organisation for the drug and alcohol sector in the UK. We represent about 400 organisations and individuals who are interested in treatment, prevention, and academic research in the area of addictions. Where am I going? Yeah, but I thought I'd start with some context. So, in the UK, prevalence of drug misuse is falling amongst adults and young people, but it's still high by international comparisons. The immediate costs associated with substance misuse by young people in the UK is estimated to be about £100 million a year. The cost of individual problem drug use over the course of a lifetime has been estimated to be between £820,000 and £859,000, depending on whether it's a man or a woman. The women's costs are higher because of childcare costs. Interventions to stop young people before the age of 21 going on to have a substance misuse problem are estimated to save most of those costs. So £736,000 would be saved if we could prevent young people going on to having problematic drug misuse. There's a bit of a delay here. Okay, so early treatment for young people under 18 has a benefit to cost ratio in the UK of between £4.5 and £8.5 pounds for every pound that's invested. That compares with adult treatment cost ratios of between £2.50 for every pound that's invested in adult treatment. So earlier treatment has better cost outcomes, it appears. And it's also worth noting that in the UK, 1 in 7 deaths of people in their 20s and 30s is related to substance misuse, and in particular to illegal drug use. So skipping through this quite quickly, there's about 1.5 million people last year who took illegal drugs before the age of 25. And as you can see, and as you perhaps might expect, that's slightly larger in the age group of 16 to 24 than it is in the younger age group. But by the age of 15, about 1 in 5 young people say that they took an illegal drug in the UK. I think I heard Bronwyn say that there were about 20,000 treatment places in the whole of South Africa. Well, we have about that many people under the age of 18 in treatment in the UK. As you can see, slightly falling over recent years. And interestingly, for me at least, there's been a divergence between the two main problem substances that young people turn up in treatment. A fall-off in the number of people who are coming because of their alcohol misuse, and an slight increase in the numbers who are coming because of cannabis misuse. And that's run slightly contrary to the general prevalence data, where cannabis use amongst young people has been steadily falling and has been a big contributor to the falls in drug use that you saw earlier in my presentation. Young people come to treatment services, to the specialist services, through a variety of routes, but most importantly they are referred through our criminal justice system, through the youth justice system, which is the bar on the left there, and then in the middle, the other bigger bar is through education services. Otherwise, there are about 10% who self-refer or are referred by families and friends. Similarly for health services and social care, and through substance misuse services themselves. We have guidance from our National Institute for Care and for Health and Care Excellence, which is based on a reading of the evidence base as it stands at the moment. And they suggest to local areas what they should be doing, which includes developing a local strategy, using the tools that they have around them, the screening tools and other tools to identify and assess the levels of risks in their community, working with parents and carers and other organisations involved with children and young people to provide support and referring them on to specialist services, the use of motivational interviews with those who are misusing substances, and offering group behavioural therapy to children who are persistently aggressive or disruptive and as therefore perhaps at high risk of substance misuse. And then offering family-based programs and structured support for children who are 11 to 16 who are disadvantaged and deemed at high risk of substance misuse. I'm going to talk a little bit about brief interventions and a project that I ran when I was working for a charity called Mentor. But before doing so, I think it's worth pointing out some of the limitations in terms of the evidence base for brief interventions. There are 3 Cochrane reviews here. One of a school-based intervention which suggests it's a promising approach, particularly for cannabis, but it's too early to say. There haven't been enough studies done for the reviewers to say this is the way forward. Secondly, a review of motivational interviewing for prevention of alcohol misuse amongst young adults, which found that it had little effect and no substantive or meaningful benefits from it. And then the third one, which suggested that long-term behaviour changes and the evidence for that are weak, and that other active treatment as usual, and being assessed and receiving feedback can be as effective as motivational interviewing. So the really big limitations about what we know about the effect of motivational interviewing and other brief interventions. Nevertheless, it looks to us as if it might be a promising way forward, partly because of its acceptability to the population and to deliverers as well. And so that's what I'm going to hopefully talk about. So I'm talking about a project I ran which is called Street Talk, which was a project to train youth workers to deliver brief interventions to vulnerable young people. It was a short conversation in a youth work setting, either in a club or on the street, with young people who we had screened using the CRAFT screening tool. So a very brief screening tool to suggest what level of risk they might be running, and then to explore that further as part of a brief intervention. One of the innovations we used in doing this was to put the screening tool onto a mobile phone and onto tablets, which meant that they were very attractive to young people. They came and they gave us the information that we asked of them, and they didn't feel as if they were having to fill out pieces of paper, which is very boring. It gave us the ability to follow them up. We asked them to give us their mobile phone numbers as their individual signifiers, which allowed it to be anonymous and allowed us to text them and know that they were part of our study. We had security around the data. It wasn't shared with anybody else. And we had real-time information that we could use to understand what was going on in terms of the numbers of interventions that were taking place. So we knew which youth workers were doing the interventions, and we could track back how effective they might have been as well. So quickly, as you can see, mostly they were under 18. There was a fairly good split between boys and girls. You can see that most young people were taking either low risk or no risk. That's the two on the left-hand side. And then about 40% were taking medium to severe risks in their substance misuse, as assessed through the screening tools that we used. So 807 people out of the 2,000 we screened were eligible for an intervention. The disclosure of substance misuse, well, as you can see, many young people disclosed that they'd used alcohol, but the way that they used it was important to our decision about whether they entered the intervention group. And about half of them said that they had used cannabis, and a smaller group had said that they used other drugs as well. And about 35% of people said that they had polydrug use, so they were using 2 or more substances at the same time. The point of this slide is just to show that those people who are in the intervention group, the ones in the pink, they were all more likely to take part in antisocial behavior and crime than their peer group, who didn't get the intervention. So we're pretty sure that we were focused on the right group of people. These were people who were already engaging in low levels of antisocial behavior, and some cases in quite important criminal activities such as selling drugs. The sorts of behaviors that young people disclosed to us in terms of their risks were getting into trouble, their families and friends saying that they were concerned about them already. About 43% said that that was the case. Almost just over 60% saying that they either used to forget or had forgotten and blacked out as a result of their drug use. We weren't quite sure about what their answers meant on that. Using when they were alone, so almost half of people said that. Lots saying that they used them to relax, which is perhaps not surprising. And almost 60% said that they had been in a car where somebody else had been intoxicated. Quickly, the results in terms of the most basic level of the results told us that young people felt more confident about going to find somewhere to get support should they need it. And they also said that they felt better at more informed about being able to take choices in their own lives about substance misuse as a result of the intervention. You can see across this that what we found was that the intention to use more safely in the future, that they would prefer to be safer in the future, that significant others would, in their lives, their families and friends, would want them to take better choices, and that their confidence about being able to go on and do so, almost 70% across all of those said that that would be their preferred outcome as a result of this intervention. We know that the intention to change often isn't translated into actual change, but it's a good, I think, starting point for showing the kind of the positivity of such an approach with this sort of age group and people taking these sorts of risks. So the key findings from the project were that we thought that youth workers, the people that we trained, had the skills to be able to provide an early intervention with young people, and they also had the right mindset to do it. They wanted to work positively with young people. They wanted to engage with them in their own learning and in their own health behaviours. And we also found that a large majority of the young people who took part had a positive desire to deal with the risks that they were running and had a better understanding of how to do it. We found that these services need not be delivered by specialist services, that youth workers and universal settings were a good place to find young people and to deliver the interventions, and that we think that they are there was a good fit between youth workers and the sorts of methodologies that we were trying. And then finally, that the smartphones and tablets and the web surveys were very effective at engaging young people. We had very little attrition as a result of this. We found people gave us the information and then came back and did a substantially longer survey a little while later to tell us about their other behaviours. So, to conclude, so working with young people in treatment is not only about problem on drug use, but about multiple needs. Young people who are misusing substances often have other things going on in their lives. Their family relationships may not be good. Their mental health may be breaking down. Their relationship with their other institutions like schools may be very fragile. And so treating all of those things at the same time is a really important part of young people's work. We think that not all interventions need to be delivered by specialist services. There are other people out there, school teachers we heard a lot about in the session before this, youth workers in our case, primary care providers also, people who work in sexual health settings. These are all good people to deliver interventions around substance misuse. A lot of the work done by specialist drug and alcohol services is not really treatment as you would imagine it in terms of adult treatment. It's a lot of it is psychosocial and about helping young people to come to terms with growing up and helping them to understand the level of risk that they may be running. We think that polysubstance use creates a new challenge for services. The idea that just young people just use one drug at a time isn't the case anymore, and there are an increasing number of young people we find who are using quite a wide range of substances, and that makes it very complicated as to both the outcomes for them and the sorts of services that need to be on offer. We don't think that it's right just to judge young people services by the same indicators that you might use for adult treatment. And that we think the key challenges are between the gaps between young people services and adult services. You know, a lot of people who go on to develop those serious drug and alcohol problems, the ones that cost us so much money, start in their teenage years, and finding a way to make sure that when the problems that they might be experiencing at the age of 18 are taken as seriously by adult services as by young people services is a really important part of thinking through these challenges. We think that young people are often involved in supply. When we talk to young people, what they tell us is they get their drugs from each other, not from drug dealers. Obviously, somebody does, but there's a lot of social supply, and those young people need to be to have interventions that are specifically tailored towards them. And that we need to make sure that there are environmental prevention techniques used as well as the individual techniques. So invest in your community and social regeneration as well as one-to-one support. And that's me done. Thank you very much.